So much. Morning, everybody. I hope I can I can experience some of your grace for being very late this morning. Yes, as Ralph said, my name is Keisha, and I'm going to do the presentation on sickle this morning. Can I just have an idea of how many people have joined the specialty of hemoglobinopathy in the last 18 months, 24 months? Hands up. Welcome. Nice to see you guys. Um, how do I? Okay, thanks. Next slide, please. So I just wanted to introduce or just share some history about the West London HCC, but also about the Bren Sickle Cell Centre, which is the service that I'm part of. So the centre has a long history with the Sickle Cell Society, both launched in 1979, and some of the key personnel from that centre or that service helped to launch the Sickle Cell Society. So I know I've chosen a very young picture of her, but I'm sure you recognize Dame Elizabeth Anyowu on the left and on the other picture on the left. So she's your first sickle cell nurse in the country. Yes, so the service sort of spearheaded from the Bren Sickle Cell Centre. Yeah, so I just wanted to take some time to just quickly go through how services are commissioned in the UK at the moment. There are going to be some changes as we have some movement and some mergers between the Department of Health and Social Care and NHS England. But ideally, a few years ago, there was a report that showed there were inequality in the way services were delivered in the UK. And from that came sort of like a structure of how best that we should be delivering sickle cell care in the UK. So at the bottom, we've got local hemoglobinopathy teams or LHTs. These are your DGHs, further out of London. And, they have, most of them have, an A&E. They may have a hematology department within them, but there's no specialist services within those. So the LHTs then fit or feed information up to the SHTs. And within West London, our SHTs are St. George's and the Hammersmith and Norfolk Park on London Northwest, which is the service that I'm part of. So at our specialist teams or our specialist centers, we're expecting to deliver a lot more specialist care. So all your scans and all your clinics and all your investigations happen there. Some centers are able to deliver more sort of tertiary type style investigations. If they're not, then they feed into the HCC. So our HCC here is based at Imperial. And so this is where you have access to, sorry, all the research and, sort of trials that are happening. But we also have an HCC MDT. So if we are challenged or having concerns with patients at the other two levels, then we present our patients to the HCC, where a lot of the specialists services and colleagues sit, including our transfusion leads and also our bone marrow transplant leads, Dr. De La Fuente. At the top of the pyramid is a national panel. So this is where lots of decision making is happening. We talked about COVID. So when COVID was happening, information was coming down through NHS England, down to the national panel, making decisions about how COVID should be impacting our sickle patients and what advice to give them. So lots of changes in regards to how care is delivered is discussed at the panel level. So if you're within sickle cell, you may know about the sickle cell and thalassemia APPG group. This group launched an inquiry into the death of a couple of patients that happened, one at Norfolk Park, but the one that I think is most people are aware of, which is widely advertised in the media, Evan Nathan Smith at North Middlesex Hospital. So this was triggered by the coroner's report, the death of Evan Nathan Smith, and it also mentioned our patient at London Northwest, Tyrone Airy. So the APPG had 3 evidence sessions. with contributions from patients, politicians, and clinicians. There were 31 recommendations, but there were two fundamental points that came out of that report. The first one was a deep sense of anger. Patients felt that concerns were continually being flagged and nothing really was being done about it. And then there's the elephant in the room, a question of race. So key themes, I feel like I'm in the wrong place because I need to keep looking at the screen. There was substandard care for patients if they found themselves on general wards and in ED. There's a failed joint up service in regards to how patients are looked after. There was low awareness of sickle cell, so we're glad everybody's in the room and hopefully today helps with that. Negative attitudes towards patients with sickle cell, I think some of that was touched on by Jeremy and Ua. And then inadequate investments in care, which NHS England is trying to correct at the moment. This video, I think I will share that later, maybe in the break. So let's talk about sickle. It's the most common genetic condition in the UK, but also if we look at worldwide, numbers are quite massive. And really staring from sub-Saharan Africa, but there are millions of people affected with sickle cell in the world. So, as I mentioned, it's one of the most common genetic conditions worldwide, and in the world, there's about 275,000 born every year. 2/3 of them affected in sub-Saharan Africa. And almost all newborns in well-resourced countries, including the UK, live well into adulthood. The introduction of penicillin has made such a difference over the last 40, 50 years, changing and reducing mortality for patients with sickle cell disease, and also increasing the life expectancy. So in the UK, before we would be quoting numbers about 12,000, 15,000, we are growing. We have a national haemoglobinopathy register, and we guesstimate about 18,500 patients on the register so far. And these are the ones that we know about. You know, and I know that there are people within the community that we haven't touched yet. So about 70% of them live in Greater London, and every year there's 350 births in the UK. So at London Northwest or Centre, we've got about 420 adult patients and about 180 pediatric patients. So sickle cell disease, very simply, affects the HBB gene found on chromosome 11. At 0.6, you have a substitution of valine for glutamic acid. And if you have sickle cell anemia, then both alleles are affected. If you have another type of sickle cell disease, not sickle cell anemia, you have a compound heterozygous condition like SC, SO, SD. And if you have only one affected allele and a normal adult hemoglobin, you're known to have sickle cell trait or be a carrier. So this is the inheritance pattern for people who are carriers. Pre-implantation diagnosis as well. So there are major types of sickle cell disease. The ones at the top, I'm sure you know, you've seen them very often. And then there's the other ones that we don't see as much, but they are in the community and they still attend clinics. So basically, what is sickle cell? So you've got red cells that carry sickle hemoglobin, and under hypoxic conditions, they polymerize or they change the shape of the sickle hemoglobin within the red cell, which then distort the cells. That distorting of the red cells make the cells very dense. They're not very good or have poor affinity to oxygen. And I think the main thing is that they cause a lot of tearing within the vasculature. So these red cells, they're inflexible and they contribute to sort of premature hemolysis and inflammation. We'll see a bit later on some of the treatments that we, aim to try and support people with sickle cell disease looking at that inflammatory issue. So you've got early damage to micro tearing of the blood vessels. The wall induces endothelial inflammation and may lead to chronic vascular damage. Ooh. Few slides back. Yeah, great. Yeah, I think over time you've got this occlusion happening in sickle cell disease, damaging to the blood vessels, which causes a lot of problem, tearing, scarring, and it also activates the endothelial cells. So chronic inflammation is a huge thing. And it leads to increased expression of adhesion molecules. And this is part of the challenge we see with sickle cell, where that stickiness happens, not just on the red cell, but on all the cells. So as we know, when you have that stickiness happening with all the cells, everything slows down. And then I think what you then have is kind of like a soup. So as Ralph mentioned, I'm from the Caribbean island of Tobago. There's a one pot thing that we call pilau, where you have meat, rice, vegetables, or peas in it. And I often think about that when I think of a sickle cell crisis, because when we explain it to patients, we explain it very simple. Red cells break down, they stick together. Yes, they do, but actually there's a lot of things happening at the same time. You've got white cells and platelets and everything happening, the damage to the blood vessels and the blood wall. All of that coming together, creating a bit of a traffic jam, as I kind of explained to the pediatric patients. So you have a reduction of blood flow, which promotes hypoxic conditions, along with the consequence occlusion of the vessel, and that also helps induce more polymerization. And then you have hemolysis happening with your red cells not living very long, breaking down, then leading to anemia. So when we think about a patient in a sickle cell crisis, it's like an iceberg. There's lots of things happening. So what we see at the top is the pain, and we're trying to treat that. But what is actually happening below the surface? You've got vascular occlusion, multicellular adhesion or stickiness, and inflammation wildly causing havoc. So sickle cell crisis or vaso-occlusion, VOCs, are major burden for sickle cell patients, and they represent about 90% of admissions to hospital every year. And, the impact of that has lots of other complications leading on to that and associated with affecting the quality of life, end organ damage, multi-organ failure, and death. So anemia is due to chronic hemolysis, and then you've got vaso-occlusion, which happens, episodically. You've got long-term chronic damage for patients, which then results in a combination of anemia and vascular occlusion crisis happening continuously. I'm not going to go through all of this on this slide. Feel free to take pictures, but basically, wherever blood flows, you can have a problem. And you have your acute complications in sort of the yellow pockets, and then you've got your chronic or long-term complications in the sort of greenish one. So things like leg ulcers, which sometimes people don't think about. But I know that we're aware of retinopathy, acute chest syndrome, septicemia, priapism that can happen, gallstones, risk of strokes, and lots of other things as well. So just quickly going through some of them. Someone mentioned about pediatric patients. So dactylitis and splenic secretration, we see a lot more in pediatric patients. And aplastic crisis can happen up until about in their 20s. Acute pain, so this is, as I mentioned, one of the main and the leading causes of presenting to A&E. Acute chest syndrome, increased risk of stroke. So as we know, people with sickle cell disease, they have a poorly functioning spleen, or they a splenic, where their spleen doesn't work. But I think most patients have about 10% functionality, and which puts them at risk of picking up infections, and which is why prophylactic penicillin is encouraged. We know a lot of the adult patients don't take them. Una. And I tend to have a little bit of a negotiation with my adult patients. So that risk that we see sort of declines somewhat after the age of 25. But once you hit 50, the risk of septicemia then includes, pneumococcal septicemia, then sort of increases again. So I then encourage as a huge push to get my adult patients, once they pass the age of 50, to start taking penicillin again. In the meantime, we have a negotiation where they have a rescue pack. They keep 7 days worth in their cupboards, and if they start having any concerns about chest or having sort of colored sputum, I encourage them to take it, as well as obviously come into hospital if they're unwell. Priapism, I'll go through that a little bit further, and then stroke. So I wanted to talk about acute chest syndrome, which is the leading cause of death in sickle cell disease, and what do you do? It's quite an interesting one, because many patients come in, they may complain of chest pain, but not always. Some of them will complain of back pain, sometimes radiating to the front. But we tend to think about if there's pain in that area, if there's difficulty in breathing, if you've got SATs below 94, if you're coughing, if you're pyrexial, if you're tachycardic and you've got some bronchial breathing, we need to do some imaging, and usually that's by chest x-ray. Acute chest syndrome can kind of creep up on you, because a patient might come in, you might do a first x-ray and things are good. Then you repeat that after 4 hours and then it looks like this. Quite dangerous. So firstly, we want to ensure that we've got adequate analgesia, because pain is a huge issue, and encourage deep breathing. So if you've got spirometers that you can give the patient, for children and young children, we tend to use bubbles, but we might need to get physiotherapy in, or something more invasive like CPAP, to get some oxygen to the base. And how are we going to get rid of all this red cell sitting in the lung? Usually it's via red cell exchange, trying to reduce the patient's sickle percentage, try and get some oxygen to the base of the lungs. And observation is really important in case we need to escalate. Strokes. So you've got ischemic strokes, or you've got your hemorrhagic stroke. So we talked about how the distorted cells, they become very rigid and they cause a lot of damage. So you could have a hemorrhagic stroke where actually the constant charring of these red cells along the vascula in the brain then punctures the blood vessels and causes a hemorrhagic stroke. But most of the times people with sickle cell disease have ischemic stroke, where there's a blockage in the blood vessels. So we know that around 25% of patients tend to have strokes, usually in childhood or early 20s. Then there's a second late onset. So this is usually precipitated by fever, dehydration. Patients may complain of weakness. Everyone in the room should know about FAST, FACE. A stands for. So if we acronym FAST for identifying a stroke, F stands for face, A stands for arm, yes, S stands for speech, and T stands for time to call, yeah? So yeah, sometimes you have simple things like confusion, but if there is a change in the patient's face, if they have limb weakness, we're going to start thinking that possibly something else is going on. Mainly, there's a change in behavior as well. So management includes, we want to be able to scan the patient's brains. We want to identify what's happening. And again, the treatment is usually doing a red cell exchange to reduce that S percentage. and we need to get observations done, fluids, and we'll be, identifying if there's any other causes as well. Priapism I want to talk about. Lots of ladies in the room. Any male? Hey, one. Anybody else? Two? Yes. I think sometimes young male patients might be a little bit embarrassed talking about priapism. I guess as a pediatric trained nurse, it was surprising to learn a few years ago that there was a patient at GSTT at 6 months of age that had priapism. I would normally have conversations with children in their pre-pubertal stages talking about priapism up to adult patients, but just something to look out for. And when we do new birth visits, we tend to speak to parents of baby boys about priapism very, very early. So what do we have? It's an unwanted, sustained, painful erection. So has nothing to do with how pretty you look in your uniform or what lipstick you're wearing. This is unwanted, it's painful, and it can't be controlled. Normally, we're more concerned if it happens for more than 2 hours. So you have sustained priapism, or you have stuttering priapism, where you've got the penis becomes erect and then flaccid up and down. But if in its entirety is happening more than 2 hours, then the patient needs to come into A&E for quick intervention. So what do we do? IV fluids, analgesia because it's painful. We might give some sedation if we need to give any treatment. Some of the things that we encourage our male patients to do when they're home before they get to hospital, try to empty their bladder, have they use a warm bath. Some of these things work and some of them don't. But ideally, if it's happening for 2 hours, they need to come in. They need urgent referral to urologist to have a look. If this is not dealt with very quickly, patients can become impotent and it can affect them having kids later. So we're looking at aspiration. We're looking at injecting things like epinephrine into the tissue. And at last resort, hopefully we don't get here, we might need to have some surgical interventions and have shunts put in. Infection, yeah, main cause of complication in sickle, main driver. I talked about a lack of spleen. So we want to do a septic screen if the patient is, if they have become pyrexial, they're spiking. Let's do a septic screen. Let's check for, let's do a chest x-ray, do some blood cultures, find out about penicillin compliance. So we've had one pediatric death recently at our trust, child and mother. Both of them were our sickle cell patients, but both of them weren't taking penicillin, not poor uptake of pneumococcal vaccinations as well. And unfortunately, that child contracted pneumococcal sepsis and died. So making sure that they're up to date with their vaccinations as well. And the treatment would include antibiotics. If they're having a pain crisis at the same time, we'll give some analgesia, possibly some IV fluids as well. So what do you do when a patient comes in an acute crisis? I hope everybody in the room is aware of the universal care plans now. Yes, they're accessible via London Care Record, or you can go to the Universal Care Plan portal. So this, again, was an NHS England initiative ensuring that all sickle patients have a pain protocol that's individualized to them and has been agreed with them and their clinician. For the first sort of pages of the interface, patients have access to that. They can update their demographics. But in regards to the plan itself, that has to be agreed and signed off by a clinician, and that bit is not editable by the patient, it's editable by the clinician. So is everyone aware of the NICE guidance and the national standard for analgesia within 30 minutes? Yeah, great. So we're aiming to deliver analgesia within 30 minutes. We want to monitor the patient by accessing or finding out their pain score. If we're going to be delivering analgesia, most of the times that's opioids. So we want to be checking their sedation scores, their new scores, and flagging those things very early. Early escalation is really important. This is within my center, but some of your centers might have different numbers. But we will be really concerned if saturations drop below 94. And after the first analgesia is given within 30 minutes, we want to be able to reassess the patient, escalate if needed, and think about supplementary sort of care. So antibiotics, sort of thromboprophylactics, oxygen if needed, antiemetics, laxatives, because we know when we give opioids, these are some of the complications that patients have. So, it causes nausea and vomiting. It can cause constipation. So we want to be thinking ahead and being proactive with that. And thinking, quickly, could this be a sickle cell crisis? Could it be priapism if the patient is complaining? Urgent referral to urology needed, like I mentioned earlier. I just wanted to flag this. This is just some interventions that we put in place last year for World Sickle Cell Day at our center, which I thought was really good. Our A&E colleagues really got on board with this and really drove this. So we called it the perfect week that week. We wanted to make sure that every single patient in that week we followed everything. So I can see Act Now. I can see the banner there. I hope everybody's aware of what Act Now is. So if you come into our center at Northwick Park, again, you'll be assessed. You should be assessed within 30 minutes on the EPR system or Cerner. We've created a flag for all clinicians working in ED to identify that there's a sickle cell patient. Analgesia within 30 minutes of arrival. There's a standardized checklist that follows the Act Now acronym, which I thought was really, really good. And we also have a nurse and a doctor sitting in A&E and waving the patient through once they've had the initial assessment. And then if the patient requires 3 doses, then we escalate to PCA very, very quickly. And I mentioned about your UCPs, which you can access on Cerner. So some of the chronic complications, I think Una mentioned some of them: fatigue and anemia, worsening anemia, nephropathy, pulmonary hypertension, chronic sickle lung disease, gallstones, avascular necrosis, leg ulcers, retinopathy, iron overloading if you're having transfusions to help manage, osteopenia, and for some of our young children, growth and puberty issues and fertility problems sometimes later on. So the aims for managing sickle cell disease is looking at how we can reduce the frequency and severity of sickle cell crisis, prevention of chronic complications, improving the patient's quality of life, and trying to enhance life expectancy. So current treatments, actually, I forgot to put Libra on this, but hydroxycarbamide, I'm sure lots of you are aware of hydroxycarbamide, and it currently is our first line treatment at the moment for patients with sickle cell disease, increasing the fetal hemoglobin, reducing adhesion, and increasing hemoglobin in general as well. Most patients, I think about 60–70% of patients get good efficacy of that, and it tends to do really good. We know there's a small number of patients where it doesn't work and they fail it, and so they need to progress to something else. Depending on the type of sickle cell disease they have, they may start a top-up transfusion program, or I think we are prefacing red cell exchanges now. Stem cell transplantation, I'm sure you're aware of it. At our center, as I mentioned, Dr. De La Fuente is our expert on site at our HCC, and we have a few patients. I can see Sinju in the audience. Yes, yes. Crizolizumab, this was an IV infusion that was we were so excited about, so excited in the news. Early outcomes for this drug showed really positive feedback. However, once we started introducing it to the patients in the UK, those results weren't very good, and so it was withdrawn by NICE. Velexitol actually was withdrawn by the MHRA, not NICE, but this was a tablet form of medication that its main sort of mode of action was to increase the patient's hemoglobin. Again, just like crizolizumab, there were some safety concerns, and that was withdrawn. Gene editing, gene therapy, Casgevy. Has everyone heard of Casgevy? Yes, excellent, wonderful. So looking at editing or slicing, Cindy, correct me if I'm not using the right terminology, the patient's own genes and manipulating it and then infusing it back into the patient. And that's looking positive at the moment. And at the moment, there's a Libra study that's happening. It's a tablet form of medication, just looking at reducing or inhibiting some of those adhesion molecules. Um, we'll see how that goes. We've got a few patients on that trial at the moment. So just general management of sickle cell and what we do. The main thing is about getting that analgesia within 30 minutes. It's really important. And then further reassessment of the patient's pain and delivering that hydration. If they can drink orally, encourage that. If not, we try and get a line in. We know that these patients, their veins can be really challenging at times. Try and encourage oral if you can. Oxygenation if you need it, if they need it, if their SATs are dipping. In regards to SATs, I just wanted to mention something. There are studies that show our pulse oximeters are poor at picking up oxygenation for patients in darker skin. So if you have a patient who looks like they have increased work of breathing, who might be tippering on what we would say struggling. So you've got all your accessory muscles going, and but their SATs are still sitting around 94. They're on oxygen. Please do an ABG so that we can have an accurate record of what their oxygen level is actually, because these pulse oximeters sometimes can be inaccurate. Right, identify if there's any infection and to treat that. And then we want to reevaluate, keeping an eye on these patients. When they come into hospital in an acute crisis, it is a crisis and things can deteriorate very quickly. So I just wanted to, as you had this session with Jeremy and Una earlier, I wanted to talk about how we, there's a wider view of managing sickle cell patients, and it's not just about hospital care. So yes, we've got our hospital teams and our CNS and our clinicians, which is great, but pulling in primary care as well, our community teams, as well as your GP surgery and your practice nurses, and our psychologists as part of the team, or social workers or social prescribers to help deal with all the other challenges that patients may face that impact their presentations to hospital. Dietitian, I think there's few centers that have specialist dietitians, but I think we can try and access dietitians through our primary care practitioners. Chronic pain services, really important. You heard how important that was for Una earlier. And physiotherapy. So some patients are, some specialist services have physiotherapists. Others, we use the hospital ones to help patients. So in conclusion, sickle cell disease is a multi-system disease, which sometimes is life-threatening and requires lifelong medical care and psychosocial care. We talked about the importance of public health and the changes that NHS England are making at the moment, trying to drive some of that change nationally. Good care improves life expectancy, we know that, and quality of life. Good care reduces disease complications, including stroke and hospital admissions. And for patients going for surgery, it's really important that there's a perioperative plan put in place to avoid any, unavoidable deaths for patients in theatre. And then there is a need for both primary and secondary care to liaise and ensure that the patient's full care, comprehensive care is looked after. I've got one last slide before I finish. I wanted to talk about, has everyone seen or received a link for the workforce survey? Or has anyone completed the workforce survey? Yes? I can only see Elizabeth Erica. Okay, so myself and my colleague Debbie Omadelli, we are working with NHS England to look at the sickle and thalassemia workforce. There is a survey that is circulating. I'll get Ralph to recirculate that to the HCC again. And there is a workshop at the end of this month. Please come and see me later if you're interested. But we wanted to have a look. In 2015, there was a report done by a hematologist at the time, Kate Ryan, that looked at the workforce for sickle cell in general. And in that report, some of the findings show that within 5 to 8 years, consultants were going to be retiring, and so were nurses, and that we would have a gap, which I think we've kind of fallen into that gap. As the work for the ED bypass and the community services and that funding became available through NHS England, it was really clear that we didn't have a workforce, that we needed to find people, and appointing people into those roles became very difficult. It led to things being delayed. So we just wanted to sort of address that, have discussions about it, think about from the workforce, which is everybody in this room, what are some of the things we need to be thinking about long term? How do we continue to have a continuous supply of nurses coming through? How we upskill people, looking at the RCN competencies. I hope everyone knows about the RCN competencies. No? I'm seeing no. Okay, that's not good. Adapting new roles. One of the challenges that we can see in the sickle workforce is having a ceiling. So you get to band 7 and there's nothing really after that. So looking at what other roles we can input, and obviously we'll need funding for that. And thinking about other ways of working and what sort of leadership is required to keep this speciality going. So yeah, please see me in the break if you're interested. We'll get the survey sent out to you. And I think there's a couple of other places left for the workshop at the end of the month. That's me.
Oh, wait, can we really let you off that easily?
Hi.
Hello.
Thank you for that presentation, because you actually told me a good few things I didn't know.
Okay.
One of the questions I wanted to ask was, I do know that we can be prone to leg ulcers and so on, and I'd always thought this was a complication of sickle cell. Come to find out maybe a year ago, the issue with opiates and so on actually negatively contributes to that, and that upon reducing or stopping, ulcers can clear up quite quickly, right? So I'm assuming this is due to circulation as well as a bunch of other things. But what can we, or what should we as patients kind of be looking out for in terms of if this stuff starts to come along, the bone deterioration and so on, what can we do to start to combat a lot of those things earlier, as opposed to when it's there already and we then have to manage?
I think with sickle cell disease, because it's driving all the time, it's really difficult to tell patients, and I know we do it as nurses, drink more water, da, 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 rah, rah. Okay. Where those occlusions happen is not up to anybody, including you, right? And it affects every single patient differently. So unfortunately, the only way to sort of prevent that is to have treatment earlier. And it is why in the US, every single baby is given hydroxycarbamide from the age of 6 months. We've been very conservative in the UK. I think our clinicians over the last, I would say 10 years, have embraced it a bit more. So they have discussions with parents in pediatric clinics earlier. But in the US, they just give it. And I know the US, let's not get into a conversation about big pharma. But, but in order to prevent those long-term conditions that happen, we have evidence now. It's been 40, almost 50 years that show hydroxycarbamide does this. And recent studies have come out just concreting that evidence from before. So the best way to prevent all the long-term conditions before is starting treatment early. And as I mentioned, the first line is hydroxycarbamide. It's going to prevent all those things from happening long term. So obviously we need to think about people, children as they go into adulthood and having kids. And for women, we know that risk is, almost not worth mentioning, but for the boys, coming off of it for a few months and then allowing, them to produce sperm and then, impregnating their partners and going back onto it. But the only way is to start treatment early. Yeah.
First of all, thank you for the wonderful session. Thanks for explaining the last slide, which includes the demand for the workforce for this specialty. And also one more congratulations for being a nurse consultant, which is a privilege. Um, I just want to know about your career progression, especially how can you advise or how can you throw some light for the newly qualified nurses who aspire to be in that specialist role? So what are the courses we should undergo? How is the journey? What are the pathway?
Okay,
Please, thank you.
good question. A pathway or a journey or a framework. It's something that's rumbling in my mind to do a PhD. We'll park that for a minute. To try and develop. What I would recommend any Band 5, anybody interested in the speciality to do, one, show some interest. And the easiest way you can do that is becoming a link nurse on the ward. Once you become a link nurse, then you spend time with the CNS, understand what their work is about. Because I think as a recruiter, now recruiting patients, nurses into my service, I see a lot of people who are interested in getting a Band 7 and wearing a nice uniform and not really recognizing all the complexities that come with sickle cell disease. It's hard grafting. There's a lot of things that are up against us. So when we talk about race and health inequalities, all of those things sort of affect how well you progress, how easy jobs come up, and dealing with what can sometimes be very challenging patients. So you have to have grit, you have to have a sense of determination, and you need to love it. So if people are interested and they're coming in because they want to get off the ward and walk around and tell people what to do, in sickle, there's a lot more grafting that happens with that. You're coming into services where there's a shortage of staff, so you're going to be asked to step up very quickly. So going out, thinking about the long-term plans and trying to get into sickle and escalating up. So one, if you're a Band 5 or 6 on the ward, identify yourself, say you want to be a link nurse, identify your CNS, spend time with them, get to understand your own service, because every service is different in the country. And then you can access the RCN competencies by yourself. In the past, when I was, myself wanting to get off the wards and interested in stuff, I asked for a secondment to do different things, to go into different areas. I took time off work and spent time 1 week with a CNS to see what she does in the week, to see if that was something I really was interested in. So again, following the No One's Listening report and NHS England, offering more funding, we now have some more spaces in different areas. There are areas that are opening on the acute side, ED bypass, which I mentioned earlier, and also space coming up in community programs. The challenge we have nationally with sickle, one, oh my God, I'm going to get on my high horse right now. It is not recognized as a long-term condition. That's the first problem. And because of that, there is no ring fencing for sickle and its development or growth long-term. When money is poured into sickle, it usually is on a short-term basis in pilot projects. What we are trying to do with the guide of the Sickle Cell Society is to force NHS England to look at the health inequalities that they talk about a lot and to put those words into action so we can create posts for people like yourself to fit in. Because once you sit into a CNS post at Band 7, there's not much room for growth. So if you sit in an acute trust, there might be a space for becoming an advanced nurse practitioner. In the community, you might have space for a community matron at an 8A level. And then there isn't much else. So you congratulated me in being a nurse consultant. There's 3 of us in the country. My colleague, Natasha, is at the Homerton, and my other colleague, Sakai, is at North Mid. I think there should be more nurse consultants But the challenge we're going to have is, where's the money going to come from? So we first need to show, one, with the numbers increasing, that there is an unmet need. And so therefore, we need to sort of drive change by becoming more vocal about what's needed in the area. You can see me later because I'll go on forever. I feel really passionate about it.
I think this is the last question because I think everyone needs a break.
Oh, sadly, I had two questions, but I think the first question was following on from the young lady who asked you the question about how can we become more educated in relation to understanding sickle cell. You mentioned about us being a link nurse, but where do we go from there? I don't think, for me, I thought the question was, how do we become more educated, not to become band sevens. It was like, where do we go to find information on sickle cell and what to do with it? And I won't ask. Oh, well, the second question was really, why were those two drugs withdrawn? What were the reasons?
Okay. So yes, more education is attending days like this when you see them. But I have been super reluctant to join social media. And I joined Twitter, I think, in 2023, then jumped onto LinkedIn. And that has been the best thing for my career and my way of learning and developing. So if you don't like social media, the Red Cell Network that's based at the Whittington does, or if you Google Red Cell Network, they actually have bite-sized learning modules about sickle. And last week they launched a thalassemia model as well. So that's going to be coming onto their ATC website. We also have videos on our own website. So the West London ATC website has a lot of learning, lots of presentations that we've done. But I think I've been able to touch base and learn more and experience more by being on social media. Our trust, we have a junior doctor, Dr. Rosby Awadzi, who actually has a platform as well. I can send this on later on with Ralph, that he opened up for patients, but lots of clinicians join it as well. That's also a learning platform that you can find information. Crizolizumab and voxelotor, in regards to why they were withdrawn. Voxelotor, there was a safety element of it. It just was not working. The same with crizolizumab. So in the studies that they did, obviously they had participants, actual patients, but maybe the parameters for those patients were very narrow. Well, 2 or 3 crises. When we started giving it to patients who were deeply unwell, had multiple complications, it showed no efficacy. There was no difference. And so if it's not working and it's costing NICE and MRHA money, if there's no cost benefit to it, then they're going to withdraw it.
Okay, thank you, Keisha. That's excellent.